move their extremities very fast and lose their consciousness?
I have seen it in some movies, but I have never seen it in real life.
But were you aware this is an epilepsy or no?
No,
No? So
no.
now you are aware this is epilepsy. So and you know uh, how it looks like. And there are different kinds of epilepsy. Some of them can be with the loss of the consciousness. Some of them are without. And some of them, most of them usually uh, are with the movement, so the extremities movement. And the epilepsy cannot be treated completely, but the episodes of epilepsy can be reduced so that patients will not suffer much. And treatment is prevention. So usually there is no treatment needed during the epilepsy uh, itself. So, but the treatment is to prevent the epilepsy. So when the patient will fall down to the epilepsy, uh, then the only thing you should keep in mind that if a patient will lose the consciousness, then he or she may injure himself by falling down to the hard objects, and you should help him to lie down without damaging the brain. And then you can also hold the legs and hands so they will not uh, damage someone around, including yourself, because these movements can be very uh, fast and strong. So this is actually all that you can do for the patient in the with the uh, with the epilepsy, and after and this usually lasts for about half a minute or several minutes, no more than 5 minutes. And after that, the patient is very exhausted and falls asleep. So this is a normal for uh, the epileptics. So uh, the drugs that are used to treat the epilepsy are the same, actually. So the same group is used an uh, as a drugs for insomnia. The benzodiazepines are effective, uh, but besides benzodiazepines, so usually the clonazepam and diazepam are used from the group of benzodiazepines. But besides benzodiazepines, another groups are effective as well. And the one of the first drugs that are available for the treatment of epilepsy is valproic acid, and valproic acid is one of the most commonly used drugs for the epilepsy. Uh, Still, there are more safe and effective drugs available now, and these include phenytoin, and also there are many other drugs that are effective for the epilepsy, and they are from the different groups, and there are drugs that are older, like diazepam, carbamazepam, divalproex, lorazepam. So lorazepam, diazepam, and carbamazepine are the benzodiazepines, and then phenobarbital is used in children only, and it is a barbituric acid derivative, and then phenytoin uh, is not a benzodiazepine but a specific anti-epileptic drug. So phenytoin was one of the first most commonly used drugs, and diazepam is usually used for the status epilepticus, and introduced intravenously. There are also newer drugs that were uh, were available in after the year of 2000, and these are very different groups. So there are many groups, chemical groups here, and they are equally effective, and the only difference is the adverse effects, and these include uh, these include the uh, phosphenol, that is the derivative of the phenytoin, that is long acting, and also the S-carbamazepine, that is derivative of the carbamazepine, and then the lacosamide and lamotrigine, and also vigabatrin. So these are newer drugs that are still used, but usually phenytoin is one of the drugs of choice for the treatment. So these are the most commonly drugs used. So the etiology of the seizures are not completely known, but I'm sorry the connection was lost, so hope you are reconnected too. So the etiology of seizures is not completely known, but there is some sort of focal areas that are abnormal and may trigger into the activity by charges, and these can result from the change in the blood gases, the pH, and the ions, and also blood glucose and changes in environment. The environment factors that may affect the seizures are sleep, alcohol intake, and stress. Most patients can predict the epilepsy syndromes by some aura that can be felt uh, just before the symptoms will start. The neuronal discharge in epilepsy results from the firing of a small population of neurons in a specific area, and this area of the brain is called a primary focus. And we know that from the neuroimaging techniques such as MRI, that is magnetic resonance imaging, and also positron emission tomography scans, so that is PETs, and from the single photon emission coherence tomography. So these are the techniques that are used for research. And epilepsy can be due to a genetic, structural, and metabolic cause, and most of the time the cause is unknown. There are different types of the epilepsy depending on the size of the seizure, and but the reasons are mostly genetic and usually are inherited abnormality in the central nervous system, and sometimes genetic mutations can be identified in epilepsy syndromes, and the obtaining family history may provide important information for assessing the possibility of a genetic link to seizures. On the structural and metabolic epilepsy, such as can result from the illicit drug use, tumor, head injury, hypoglycemia, and also the meningeal infections that are infections of the central nervous system, or when the patient is withdrawal of alcohol rapidly, may feel some symptoms of the seizures, but in the latter case the seizure is reversible. And in cases when the cause of a seizure can be determined and corrected, medication may not be necessary, like for example during the withdrawal from the alcohol, or seizure can be caused by a drug adverse reaction, and that is not an epilepsy and does not require the treatment. So you only need to stop taking the drug. So just discontinue the drug, and then epilepsy will go away. So some Drugs have adverse effects and may lead to seizures. Uh, and sometimes the reason for the seizures cannot be corrected, and then one should use medications for the treatment. And also the cause of the seizures can be unknown, and this is the most common case. And usually there is no specific anatomic cause of the seizure, uh, such as trauma or neoplasm, and patients may be diagnosed with seizures where the underlying cause is unknown. So, and patients should be treated chronically with epilepsy medication or vagal nerve stimulation. So the classification of seizures includes the focal seizures, and focal seizures involve only a portion of the brain, typically part of one lobe of one hemisphere. The symptoms of each seizure type depend on the site of neuronal discharge and on the extent to which the electrical activity spreads to other neurons in the brain. Focal seizures may progress to become generalized tonic-clonic seizures. So I assume that you already familiar with biochemistry, and also if you have any questions when you discuss the topic, please ask. Uh, so if you hear some word that you don't understand, or the definition that you don't understand, then you should ask immediately. So the focal seizures may progress to become generalized tonic-clonic seizures, and focal seizures are divided to simple partial. These seizures are caused by a group of hyperactive neurons exhibiting abnormal electrical activity and are confined to a single locus in the brain. The electrical discharge does not spread, and the patient does not lose consciousness or awareness. The patient often exhibits abnormal activity of a single limb or muscle group that is controlled by the region of the brain experiencing the disturbance. The patient may also show sensory distortions. This activity may spread, and simple partial seizures may occur at any age. Then the second type of the focal seizures is complex partial. These seizures exhibit complex sensory hallucinations and mental distortion. Motor dysfunction may involve chewing movements, diarrhea, and or urination. Consequences are altered, and simple partial seizure activity may spread to become complex and then spread to a secondary generalized convulsion. Complex partial seizures may occur at any age. Generalized seizures may begin locally and then progress to include abnormal electrical discharges through both hemispheres of the brain. Primarily generalized seizures may be convulsive or non-convulsive, and the patient usually has an immediate loss of consciousness. The first subtype of the generalized seizures is tonic-clonic. These seizures must result in loss of consciousness followed by tonic and clonic phases. The tonic phases are continuous contractions, and the clonic phases are rapid contractions and relaxations. The seizure may be followed by a period of confusion and exhaustion due to the depletion of glucose and energy stores. That is why patients are usually fall asleep or maybe very, very tired. The second type of the generalized seizures is absence. These seizures involve a brief, abrupt, and self-limiting loss of consciousness. The onset generally occurs in patients at 3 to 5 years of age and lasts until puberty or beyond. The patient stares and exhibits rapid eye blinking, which lasts for 3 to 5 seconds. An absence seizure has a very distinct 3 per second spike and wave discharge seen on electroencephalogram. The third type is myoclonic. These seizures consist of short episodes of muscle contractions that may recur for several minutes. They generally occur after wakening and exhibit as brief jerks of the limbs. Myoclonic seizures occur at any age but usually begin around puberty or early adulthood. Clonic seizures consist of short episodes of muscle contractions that may closely resemble myoclonic seizures. Consciousness is more impaired with clonic seizures as compared to myoclonic. And tonic seizures, these so there are tonic, clonic, then absence, myoclonic, and then clonic and tonic. Tonic is the type of the seizure, it's not a drink. So these seizures involve increased tone in the extension muscles and are generally less than 60 seconds long. And the last type is atonic. These seizures are also known as drop attacks and are characterized by a sudden loss of muscle tone, and the patient usually falls to the floor. So this is the generalized 6 types of the generalized epilepsies. The mechanism of action of anti-epilepsy medications is based on the blocking voltage-gated channels, potassium and calcium, enhancing the inhibitory gamma-aminobutyric acid GABA adjunct impulses, and interfering with the excitatory glutamate transmission. So GABA and glutamatic acid are the primary inhibiting neurotransmitters in the brain. Some anti-epilepsy medications appear to have multiple targets within the central nervous system, whereas the mechanism of action for some agents is poorly understood. And anti-epilepsy medications suppress seizures but do not cure or prevent the epilepsy. The choice of drug treatment is based on classification of seizures and patient-specific variables like age, comorbid medical conditions, lifestyle, and personal preference, and characteristics of the drugs such as cost and drug interactions. For example, focal onset of seizures are treated with the different set of medications. Then primary generalized seizures, although the list of effective agents overlaps. The toxicity of the agent and characteristics of the patient are major considerations in drug selection. In newly diagnosed patients, monotherapy is instituted with a single agent until seizures are controlled or toxicity occurs. Compared to those receiving combination therapy, patients receiving monotherapy exhibit better medication adherence and fewer side effects. If seizures are not controlled with the first medication, monotherapy with an alternative medication or the addition of medication should be considered. Failing that, other medical management like vagal nerve stimulation surgery are available and they should be considered. Awareness of the anti-epilepsy medication available and their mechanism of action, pharmacokinetics, potential for drug-to-drug interactions, and adverse effects is essential for successful treatment of the patients. The So the new drugs that are approved in recent years in 20th century have some uh, potential advantages over the drugs approved prior to 90s in terms of the pharmacokinetics, tolerability, and reduced risk of drug-to-drug interactions. However, studies that fail to demonstrate that the new drugs are significantly more efficient than the older agents. For that reason, the anti-epilepsy medications are described below in without any preference by efficacy. So the choice of the first drug is based not on efficacy. So usually it's based on the tolerability and all of the drugs are equally effective for the treatment. The suicidal behavior and suicidal ideation have been identified as a risk with anti-epilepsy medications. In addition, virtually all anti-epilepsy medications have been associated with multi-organ hypersensitivity reactions, that is, a rare idiosyncratic reaction characterized by rash, fever, and systemic organ involvement. So the first group is benzodiazepines, and benzodiazepines bind to GABA inhibitory receptors to reduce firing rate. Most benzodiazepines are reserved for emergency or acute seizure treatment due to tolerance. However, clonazepam and clobazam may be prescribed as adjunctive therapy for particular types of seizures. Diazepam is also available for rectal administration to avoid or interrupt prolonged generalized tonic-clonic seizures or clusters with oral administration is not possible. And the carbamazepine, that is the second benzodiazepine, actually the sodium channel blocker, and carbamazepine uh, inhibits the generation of repetitive action potentials in the epileptic focus and prevent their spread. Carbamazepine is effective for treatment of focal seizures and additionally generalized tonic-clonic seizures. It also is prescribed for bipolar disorder. Carbamazepine is absorbed slowly and erratically following oral administration and may vary from genetic to from the different manufacturers. So different generics are available and are resulting in large variations in serum concentrations of the drug. Usually the different genetics are not uh, vary much, but carbamazepine is an exception. It induces its own metabolism, resulting in lower total carbamazepine blood concentrations at higher doses. Carbamazepine is an inducer of cytochrome P1A2 uh, and 2C and 3A and UDP glucose sulfonyluretransferase or UGT enzymes, which increases the clearance of other drugs. Hyponatremia may be noted in some patients, especially the elderly, and may necessitate a change in medication. Carbamazepine should not be prescribed for patients with absence seizures because it may cause an increase in seizures. Eslicarbazepine Eslicarbazepine acetate is a prodrug that is converted to the active metabolite eslicarbazepine by hydrolysis. Eslicarbazepine is the active metabolite of oxarbazepine. It is a voltage gated sodium channel blocker and is approved for partial onset seizures in adults. Eslicarbazepine exhibits linear pharmacokinetics and is eliminated via glucuronidation. The side effect profile includes dizziness, somnolence, diplopia, and headache. Serious adverse reactions such as rash, psychiatric side effects, and hyponatremia occur rarely. Ethosuximide reduces propagation of abnormal electrical activity in the brain, most likely by inhibiting T-type calcium channels. It is only effective in treating absence seizures. Ezogabine is thought to open voltage-gated M-type potassium channels, leading to stabilization of the resting membrane potential. Ezogabine exhibits linear pharmacokinetics and no drug interactions at lower doses. Possible unique side effects are urinary retention, QT interval prolongation that leads to the arrhythmias, blue skin discoloration, and retinal abnormalities. Philbamate has a broad spectrum of anticonvulsant action with multiple proposed mechanisms including the blocking of voltage-dependent sodium channels, competing with the glycine coagonist binding site on the N-methyl aspartate or NMDA glutamate receptor, blocking of calcium channels, and potentiating GABA action. It is an inhibitor of drugs metabolized by cytochrome P2C19 and induces drug metabolized by cytochrome P2A4. It is reserved for the use in refractory epilepsies, particularly Lennox-Gastaut syndrome, that is seen in the newborns and the children because of the risk of aplastic anemia and hepatic failure. So aplastic anemia and hepatic failure are the adverse effects of the felbamate. Gabapentin is an analog of GABA, that is gamma-aminobutyric acid. However, it does not act as GABA receptors, enhance GABA action, or convert to GABA. Its precise mechanism of action is not known. It is approved as adjunct therapy for local seizures and treatment of post-therapeutic neuralgia. Gabapentin exhibits nonlinear pharmacokinetics due to its uptake by a cerebral transport system from the gut. Gabapentin does not bind to plasma proteins and is excreted unchanged through the kidneys. Reduced dosing is required in renal disease. Gabapentin is well tolerated by the elderly population with partial seizures due to its relatively mild adverse effects. It may also be a good choice for the older patients because there are fewer drug interactions. Lacosamide in vitro affects voltage-gated sodium channels, resulting in stabilization of hyperexcitable neuronal membranes and inhibition of repetitive neuronal firing. Lacosamide binds to collapsin response mediated protein 2 or CRNP2, phosphoprotein involved in neuronal differentiation and control of axonal outgrowth. The role of CRNP2 binding in seizure control is unknown. Lacosamide is approved for adjunctive treatment of focal seizures. It is available in the injectable formulation. The most common adverse effects that are limiting treatment include dizziness, headache, and fatigue. Lamotrigine blocks sodium channels as well as high voltage dependent calcium channels. Lamotrigine is effective in a wide variety of seizure types, including focal generalized absence seizures and Lennox-Gastaut syndrome. It is also used to treat bipolar disorder. Lamotrigine is metabolized primarily to the 2N-glucuronide metabolite through the UGT1A4 pathway. As with the anti-epilepsy medication, generally induces increased lamotrigine clearance, leading to lower lamotrigine concentrations, whereas valproate results in a significant decrease in lamotrigine clearance that lead to higher lamotrigine concentrations. Lamotrigine dosages should be reduced when adding valproate to therapy. Slow titration is necessary with lamotrigine, particularly when adding lamotrigine to a regime that includes valproate, due to the risk of rash, which may progress to serious life-threatening reactions. Levetiracetam is approved for adjunct therapy of focal onset myoclonic and primary generalized tonic-clonic seizures in adults and children. The exact mechanism of anticonvulsant action is unknown. It demonstrates the high activity for synaptic vesicle protein, CV2A. The drug is well absorbed orally and excreted in urine mostly unchanged, resulting in few to no drug interactions. Levetiracetam can cause mood alterations that may require a dose reduction or change of medication. Oxcarbazepine is a prodrug that is rapidly reduced to the 10-monohydroxy metabolite responsible for its anticonvulsant activity. 10-monohydroxy blocks sodium channels, preventing the spread of the abnormal discharge. It is also thought to modulate calcium channels. It is approved for use in adults and children with partial onset seizures. Oxcarbazepine is a less potent inducer of cytochrome P2A4 and UGT than carbamazepine. The adverse effect of hyponatremia limits its use in the elderly. The next is perampanel. Perampanel is a selective gamma amino 3 hydroxy 5-methyl 4 isoxalichronic acid antagonist, resulting in reduced excitatory activity. The perampanel has a long life, enabling once daily dosing. It is approved for adjunctive treatment of partial onset seizures in patients 20 years old or older. Perampanel is a newer anti-epileptic agent, and limited data are available in patients. Phenobarbital and primidone are the primary mechanism action of phenobarbital is enhanced of the inhibitory effect of GABA-mediated neurons. Primidone is metabolized to phenobarbital and phenylacetylmalonamide, both with anticonvulsant activity. Phenobarbital is used primarily in the treatment of status epilepticus when other agents fail. So because of the toxicity and the potential for the illicit drug use, for the drug abuse. Phenytoin and phosphonetoin block voltage-gated sodium channels by selectively binding to the channel in the inactive state and slowing its rate of recovery. It is effective for treatment of focal and generalized tonic-clonic seizures and in the treatment of status epilepticus. Phenytoin induces drug metabolized by the cytochrome 2C and cytochrome 3A families and the UGT enzyme system. Phenytoin exhibits saturable enzyme metabolism, resulting in nonlinear pharmacokinetics properties. Small increases in the daily doses can produce large increases in plasma concentration, resulting in drug-induced toxicity. Depression of the central nervous system occurs particularly in the cerebellum and vestibular system, causing nystagmus and ataxia. The elderly are highly susceptible to these effects. Gingival hyperplasia may cause the gums to grow over the teeth. Long-term use may lead to development of peripheral neuropathies and osteoporosis. Although phenytoin is advantageous due to its low cost, the actual cost of therapy may be much higher, considering the potential for serious toxicity and adverse effects. Phosphonetoin is a prodrug that is rapidly converted to phenytoin in the blood within minutes, whereas phosphonetoin may be administered intramuscularly. Sodium phenytoin should never be given intramuscularly. as it causes tissue damage and necrosis. Fosphenytoin is the drug of choice and standard of care for intravenous and intramuscular administration of phenytoin. Because of sound alike and look alike trade names, there is a risk for prescribing errors. The trade name of fosphenytoin is Cerebrix, which is easily confused with Celebrex, the cyclooxygenase 2 inhibitor of Celexa, the antidepressant. So keep that in mind when you dispense the drug. Pregabalin binds to the alpha 2 sigma side and auxiliary subunit of voltage gated calcium channels in the central nervous system, inhibiting excitatory neurotransmitter release. The exact role this plays in the treatment is not known, but the drug has proven effects on focal onset seizures, diabetic peripheral neuropathy, post-therapeutic neuralgia, and fibromyalgia. More than 90% of pregabalin is eliminated renally. Dosage adjustments are needed in renal dysfunction. It has no significant metabolism and few drug interactions. Weight gain and peripheral edema have been reported. The rufinamide acts as sodium channels and is approved for the adjunctive treatment of seizures associated with Lennox-Gastaut syndrome in children over aged 4 and in adults. Rufinamide is a weak inhibitor of cytochrome P2E1 and a weak inducer of cytochrome 3A4 enzymes. Food increases absorption and peaks serum concentrations. Serum concentrations of rufinamide are affected by either epilepsy medications. As with other epilepsy medications, it is induced by carbamazepine and phenytoin and inhibited when given with valproate. Adverse effects include the potential for shorter QT intervals. Patients with familiar short QT syndrome should not be treated with rufinamide. Tiagabine blocks GABA uptake into presynaptic neurons, permitting more GABA to be available for receptor binding, and therefore it enhances inhibitory activity. Tiagabine is effective as adjunctive treatment in partial onset seizures. In post-marketing surveillance, seizures have occurred in patients using tiagabine who did not have epilepsy. Tiagabine should not be used for indications other than epilepsy. Topiramate has multiple mechanisms of action. It blocks voltage-dependent sodium channels, reduces high-voltage calcium channels, is a carbonic anhydrase inhibitor, and may act as glutamate to name sites. Topiramate is effective for use in partial and primary generalized epilepsy. It is also approved for prevention of migraine. It inhibits cytochrome P2C19 and is induced by phenytoin and carbamazepine. Adverse effects include somnolence, weight loss, and paresthesias, renal stones, glaucoma, oligodendrosis, that is decreased sweating, and hypothermia have also been reported. Valproic acid and divalproex are Sodium channel blockers and GABA transaminase blockers and act on the D-type calcium channels. These varied mechanisms provide a broad spectrum of activity against seizures. It is effective for the treatment of focal and primary generalized epilepsies. Valproic acid is available as a free acid. D-valproic sodium is a combination of sodium valproate and valproic acid that is converted to valproate when it reaches the GI. It was developed to improve GI tolerance of valproic acid. All of the available source forms are equivalent in efficacy, valproic acid and sodium valproate. Commercial products are available in multiple salt dosage forms and extended release formulations. Therefore, the risk for medication errors is high, and it is essential to be familiar with all preparations. Valproate inhibits metabolism of the cytochrome P2C9, UGT, and epoxide hydrolyse systems. Rare hepatotoxicity may cause a rise in liver enzymes, which should be monitored frequently. Teratogenicity is also of great concern. Vigabatrin acts as an irreversible inhibitor of gamma-aminobutyric acid transaminase GABA-T. GABA-T is the enzyme responsible for metabolism of GABA. Vigabatrin is associated with visual field loss ranging from mild to severe in 30% or more of patients. Vigabatrin is only available through physicians and pharmacies that participate in the restricted distribution share program. So this share program includes the ophthalmologist visits. So when the patients start the treatment, their vision is checked with the ophthalmologist, and are they are obligated to visit ophthalmologist every month, and then the truthful check of the vision is required every 6 months. So this is a part of the SHARE program. SHARE is the abbreviation. Oh. So zonisamide is a sulfonamide derivative that has a broad spectrum of action. The compound has multiple effects, including blockade of both voltage-gated sodium channels and T-type calcium channels. It has a limited amount of carbonic anhydride activity. Zonisamide is approved for use in patients with focal epilepsy. It is metabolized by the cytochrome 3A4 enzyme. It may, to a lesser extent, be affected by cytochrome P2A5 and P2C19. In addition to typical central nervous system adverse effects, zonisamide may cause kidney stones. Oligohydrosis has been reported, and patients should be monitored for increased body temperature and decreased sweating. Zonisamide is contraindicated in patients with sulfonamide or carbonic anhydrase inhibitor hypersensitivity. In status epilepticus, that is 2 or more seizures occur without recovery or full consciousness in between episodes. These may be focal or primary and generalized, convulsive or non-convulsive. Status epilepticus is life-threatening and requires emergency treatment, usually consisting of administration of a fast-acting medications such as benzodiazepine followed by a slower-acting medication such as phenytoin. So the Women of childbearing potential with epilepsy require assessment of their anti-epilepsy medications in regard to concentration and pregnancy planning. Several anti-epilepsy medications increase the metabolism of hormonal contraceptives, potentially rendering them ineffective. These include phenytoin, phenobarbital, carbamazepine, topiramate, carbazepine, rufinamide, and clobazam. These medications increase the metabolism of contraceptive regardless of the delivery system used, for example, patch, rings, implants, or oral tablets. Pregnancy planning is vital, and many anti-epilepsy medications have the potential to affect fetal development and cause birth defects. All women considering pregnancy should be on high doses of folic acid prior to conception. Divalproics and barbiturates should be avoided. If possible, women already taking divalproic should be placed on the other therapies prior to pregnancy and consult about the potential for birth defects, including cognitive and behavioral abnormalities and neural tube defects. The pharmacokinetics of anti-epilepsy medications and the frequency and severity of seizures may change during pregnancy. Regular monitoring by both an obstetrician and neurologist is important. All women with epilepsy should be encouraged to register with the anti-epileptic drug pregnancy registry, and then should be monitored during the whole period of the pregnancy. So these are all drugs for today. Any questions? No questions? Then thank you for attending. See you next week.
See you. Teacher.
Salma, any questions?
No, thank you, teacher.
No? It's my pleasure to see you every week. So in case I will not see someone, then please see the recording of the classes on online on YouTube, and I hope we will gather together next week. So actually we have classes 2 weeks, so 2 more weeks, so and then the classes are over. So thank you for attending again, and bye bye.
Bye bye.
Goodbye.